Good afternoon all. Thank you for this opportunity. I'm Dr. AMRUTHA from Government Medical College, Kozhikode. Today I'm here to present a case on MOG positive bilateral optic neuritis. So small background. Optic neuritis is a cardinal manifestation of multiple sclerosis, aquaporin 4 IgG and myelin oligodendrocyte glycoprotein IgG associated disease. However, the prevalence of MOG IgG seropositivity in isolated optic neuritis is unclear. So a 36-year-old male, a known case of bilateral optic neuritis, anti-MOG positive, presented with complaints of sudden onset blurring of vision both eyes for a duration of 2 days. There was associated pain on eye movements as well. During his first presentation in June 2019, there was sudden onset of blurring of vision of 1 day duration, pain on eye movements, and he had no non-comorbidities. His visual acuity was 6/6 in the right eye and perception of light in the left eye. He had grade 1 RAPD in the left, and central field examination showed a centrocecal scotoma. His fundus examination showed a temporal pallor of left disc. Anterior chamber and vitreous were clear, and there were no signs of any chorioretinitis. MRI brain was taken, and left optic nerve hyperintensity with post-contrast enhancement was seen, suggestive of left optic neuritis. He was treated with IV methylprednisolone pulse therapy followed by oral steroids, and his visual acuity in the left eye drastically improved to 6/9. And in November 2020, he presented with similar complaints in the right eye. MRI was taken, and it showed hyperintense signals of both optic nerves, suggestive of bilateral optic neuritis. Following, IVMP pulse therapy was given, and his vision improved. A neurology consultation was made, and he was evaluated for MOG and NMO antibody, and MOG was found to be positive, and NMO was found to be negative. In April 2021, again, he had an episode of anti-MOG associated encephalomyelitis with bilateral optic neuritis. A neurology opinion was taken, and he was started on rituximab induction following this episode. And throughout the course, he was on oral steroids. After a month of tapering steroids, OCT macula was taken, in which there was serous macular detachment in both eyes, which was probably steroid-induced. And in May 2022, he was presented with blurring of vision in both eyes. His systemic and general examinations were normal, and the vision in his right eye was half-meter counting fingers, and left eye was 6/60. Pupil was bilaterally sluggish, and color vision was defective in both eyes. VP showed prolonged P100 latency and low amplitude in both eyes. This is the OCT picture. In the right eye, there was a large serous macular detachment, and in the left eye, there was pachychoroid and ellipsoid disruption. This is a fundus picture of right eye. The media was clear, disc margins were defined, and there was a temporal pallor, and macular edema was present, vessels were normal. Left eye, media was clear, disc margins were blurred, and there was a temporal pallor, and vessels were normal. A diagnosis was made of MOG-associated optic neuritis recurrent episodes. He was treated with IV methylprednisolone pulse therapy, and he was discharged with tapered dose of oral steroids, and he was also on rituximab. On 2 weeks follow-up, he showed an improvement of 6/36 in his right eye and 6/12 in his left eye. So its conclusion, a presence of recurrent and often bilateral optic neuritis is an important clinical hallmark of MOG-associated diseases. Early and accurate diagnosis is important for selecting appropriate management, and long-term follow-up is important for MOG optic neuritis patient with prompt and adequate treatment as the key to attain a good outcome. Thank you.
Nice. There are a few comments and a few. One, in the initial episode, you said the patient came on day 1 or whatever, 1 week following an acute attack, and you mentioned temporal pallor, so which something which I would not really expect, because it's an acute. It takes 4 to 6 weeks of inflammation to produce temporal pallor. So that's just a comment. Now, as far as your main disease is concerned, there are 2 antibodies which are known right now, NMO, that is aquaporin 4, and MOG. And both, they circulate antibody, they attack various parts of optic nerve, and then that's how they cause reduced vision. Now, NMO is much more aggressive, more likely to recur versus MOG. But because now we know that the optic neuritis is because of these circulating antibodies, most of these patients would be, as soon as you know that it's positive, a lot of times, even if you don't find antibodies, they would be put on steroid-sparing anti-inflammatory agents for a longer period of time. In NMO, it might be much longer, even for MOG, for a year or two, precisely to prevent these kind of recurrences. So that's something which you should keep in mind, that if you have an evidence that antibodies are circulating, there is in all likelihood a patient may require some steroid-sparing cytotoxic agent.
Yeah, and in the next slide, you talked about the MRI being normal, I think, right? In the first episode. The MRI, okay, it was just an optic nerve involvement. So the other important thing is, of course, to look for and comment on the brain. And remember, the investigation to order when you are suspecting optic neuritis is not just an MRI brain or even with orbits, but with contrast with fat suppression and flare. Okay, this is, and if you can't remember all that much, you can actually write an MS protocol. Now it's actually kind of, clearly defined as an MS protocol in radiological terms and radiological circles. So you need all these components. You need fat suppression for the orbit to look at the optic nerve enhancement. And the other thing, that not only would there be enhancement in MOG, you may have an enhancement that is in the sheath involvement. So these are early signs that can help us before we get our blood test available in the first go itself. Sometimes, as has been done in this case, often we don't do an NMO MOG in the first episode of optic neuritis, especially because of financial reasons and also because of the availability of these blood tests. So you would probably, in your first event itself, just get an MRI done. But just remember, we don't cut corners because we get a lot of information. So the MS protocol, although more expensive, will tell us a suggestion that it may be MOG because of the perineural sheath involvement, or NMO because in the MRI it's involving parts of the brain where the aquaporin 4 is more so in the midbrain region, in the hypothalamus region. So in those areas where you know that there is a higher density, so these may help us to identify. So that is our early signpost, and as Dr. Ashman mentioned, that without waiting for it, one, we give IV methylprednisolone, and two, we discuss for a longer duration of steroids in these cases, and also think in terms of steroid sparing. But excellent, I think it's a typical case. It's a case that we all must be aware of, and something that we are increasingly seeing. So before this, we were not really understanding that, why optic neuritis that we see is different from what ONTT actually described, and now we are learning that there's so much different, and it's important for us to know because these are far more common in the Indian or in the Asian population as compared to the Western. So although still optic neuritis because of multiple sclerosis or idiopathic will be the more common one, but percentage wise we'll see a lot more NM or MOG in Asian population as compared to.
And just the last point, that all these, especially MOG patients, you should ask history of COVID or COVID vaccination, Covishield. Because there is a perception that COVID-19 infection, prior infection within a few months, if they come with optic neuritis, there is a possibility that it could have triggered one of these antibodies.
Just one simple point. If some are not in a very city, major cities, radiologists are not too much tuned. In such cases, instead of writing orbit MRI brain, that my protocol is that I just advise visual pathway. It will be little easier because technicians are doing basically the MRI. So straightway in COVID scenario, as Dr. Rasmin rightly mentioned, so straightway we can write in a one set a visual pathway with fat suppression with contrast. It will cover all.
Thank you. You can call the next.
As per our that is another, it will kill time, and we don't know the radiologist how much tune with that system.
Yes.
Neurologist, you can, but you straightway you can advise for all. Then you can diagnose
yourself. So you start
yourself.
your interventions because it is more important to start methylprednisolone unless you have a doubt to the diagnosis. So at the moment the patient presents, you get an imaging done, and you start IV methylprednisolone. We don't do too many, there are not too many other tests that are required. A baseline blood test is what we do, a basic electrolytes, just so that we don't have, because of the complications of steroid and a chest x-ray. But other than that, you can start IV methylprednisolone, get an imaging done, confirm and identify. If there are suggestions of NMO-MOG must get a neurologist opinion. Even if if the MRI is showing signs of multiple sclerosis, you must get a neurologist opinion, because then these diseases are no more related or limited to the eye. Now they are neurological diseases with ocular presentation. So the patient in the long term will have to be managed by a neurologist. As if it is absolutely normal and you think it is idiopathic optic neuritis, you may do the treatment, manage, but advise the patient that the patient should get evaluated by a neurologist, because we may miss signs of a previous neurological event, which will again show that this is a patient of multiple sclerosis presenting with optic neuritis today. So a neurological assessment in the long term in all these patients of neuritis, because finally it's a neurological